In Swedish society, the cost due to sick leave from work is around 62 billion a year, not even including sick pay and sickness benefit. Since quite many years, Sweden has stuck out as being one of the countries in the Western world where the sick leave is very, very high. Since the Swedish people in many ways at the same time is reported to be one of the most healthy people in the world, this seems like a paradox. Therefore, it also has been a big interest in the national government for more than 10 years, trying to decrease the costs. There are some built-in problems in the sick leave process that is well known and described in different ways for many years. For example, there are problems occurring in the process since there are many different actors, authorities, that are responsible for different steps in the process. The Swedish healthcare system is an important piece in the puzzle, and of course also SAS, Södra Älvsborgs sjukhus. When their patients cannot go to work due to sickness, SAS both have to provide the certificates for them to be able to get social insurance, and also because SAS have to provide the rehabilitation to return to work. For this to be able to happen, there are some different roles among the staff. There are doctors who are responsible for the treatment and also for providing the sick leave certificates. There are also others, for example, physiotherapists and occupational therapists, whose expertise lies in helping the patients increase their level of activity. Since some years, there is a new function in healthcare.
This function is supposed to be supporting the patients at their journey in healthcare on their way back to be able to work. They are also supposed to have special competences in social insurance medicine and to support the staff in questions and challenges due to this topic.
We hope this Black Bag project will help us to improve the rehab coordination's working process, both when it comes to select the correct patients, but also lead the patients through the sick leave process in a good way.
One can somewhat argue that the rehab coordinator, supported from the Swedish government, is an attempt to fill in the gaps where the sick leave process fails. But to put in another piece in the puzzle when it's already been laid can be problematic. It was shown in one aim that the main problems with finding patients that require help from the rehab coordinator is the difficulties to identify when the rehab coordinator is needed and the unclarity of its goals and purpose. During the second aim, it was found that there is a huge lack of consensus between the rehab coordinators of which patients they should work with. Therefore, our project chose to focus on the selection process of patients for the rehab coordinator.
In addition to retrieving data correlating to how the patients today are being selected for rehabilitation coordination, we've also investigated their process. All of the coordinators at SAS helped us map the current process by answering many different questions. The questions were designed to give us detailed descriptions on how they are doing their work today. In the questionnaire, they also ranked and evaluated many of their different methods. This helped us see how the process varied between them. It also helped us see that the actual process doesn't always match SAS expectations on how and why they do things.
After analyzing all related data, the variation in the process can mainly break down into two aspects. First of all, there's a lack of consensus among the organization. The consequences in that case would be the uneven quality of the sick leave rehab process, and a common understanding of the goals and the objectives for the profession, inefficient and ineffective rehab coordination, and unfair patient selection. The second is that different clinics work in different ways by nature. For example, psychiatry has more long-term sick leave cases due to chronic diseases.
To be able to evaluate the work and effects of the rehabilitation coordination, there is work to be done around what the goals truly are and how they will be measured. On our way, investigating this, it became more clear that this is bigger than selecting patients for the rehabilitation coordinator. It is about getting all the pieces of the puzzle in collaborating around the patients right. Even if there in the data collected is room for a lot more analysis, we've pinpointed some possibilities for improvement that we think will affect and stabilize the process.
The goals and purpose for the rehab coordinating at SAS is not fully known to the rest of the staff, not even to themselves in some ways. Even if there is a lack of consensus in between the rehab coordinators on what, when and how to do things, they all agree that the overall purpose and goal for rehab coordination is to help the patient back to work. Since SAS is a specialized hospital, this is one question that really needs to be addressed when establishing clear goals for the rehab coordination at SAS.
Even if there are criteria for selecting patients and accountability in the process, our investigation at SAS among both rehab coordinators and other staffs shows that these are not being used properly.
Since there is a lack of consensus on when the rehabilitation coordinator is needed and what their purpose is, they would gain value from being more known around the hospital once the goal has been established.
Increased quality in the sick leave process will be beneficial not only to the patients at SAS. A better use of all functions of staff and an optimization in their collaboration will decrease the cost for SAS, and in the long run it will benefit the costs for society in total.